of how hormones are produced, how they are acting, and how they have unique features in terms of action from that perspective. And we also discussed what can cause different endocrine disorders in that regard. So today we'll continue that and we'll use case scenarios to highlight that aspect as well. So we talked about sensing problems. Now the problems can also happen at the local activation or inactivation because a lot of these enzymes are important from that regards. And this process is more important for steroids or for peptides. Mainly for steroids because they are activated or inactivated in that regards. So metabolic defects become very, very important. So you develop diabetes insipidus in pregnancy. There is a child whom I had with nephrogenic DI, and they also had two siblings. Now, every time the mother becomes pregnant, she complains of polyuria. After pregnancy, it goes off. What is the cause?
This is a case of X-linked vasopressin defect. So,
X-linked vasopressin?
Vasopressin is activity.
Vasopressinase defect. Vasopressin receptor defect. V2 receptor defect. So mother also has, but mother has got one good enzyme. So 50% activity. Now what happens in pregnancy that precipitates it?
During pregnancy, the requirement of...
Why? That's the question. Something is produced which increases your requirement. Placenta produces
Placenta produces the vasopressin.
So placenta is producing vasopressinase that will destroy your vasopressin, causing polyuria. So this is known entity, pregnancy induced DI, which can be because of this vasopressinase defect. Non-thyroid illness, of course, the problem is in the conversion of T4 to T3. We all know about that. The DIO activity of DIO3 will become more active. DIO1 will become less active. So T4 becomes reverse T3 rather than T3. So that's why you will have that problem. Apparent mineralocorticoid excess is a very interesting scenario. We know about that condition in that there is a problem in the inactivation of cortisol in mineralocorticoid tissue. So which enzyme is responsible there? 11 beta HSD2. It is there in the mineralocorticoid responsive tissue to protect those areas. Now cortisol and aldosterone both have similar affinity to the mineralocorticoid receptor. So if you allow cortisol to enter, which is 1,000 times more in terms of the mole quantity, in terms of the mass compared to aldosterone, you will have severe hypertension and hypokalemia. So this 11 beta HSD2 converts cortisol to cortisone, preventing that. So AME, the problem is in the 11 beta HSD, which are the acquired cause of 11 beta HSD defect. Which drug can inhibit 11 beta HSD2? Licorice. Okay, what is licorice?
Licorice is a Chinese herbal medicine.
A lot of people eat that. It's available in that form. And carboxynolone is an antibiotic which can also inhibit that. So that is something which is there. Now, more common, obviously, metabolism defect we know is a VDDR1. VDDR1 is conversion of 25 to 125 hydroxylase. So if vitamin D is not getting activated, you will have clearly rickets and early onset problem. If you have too much of 1-alpha hydroxylase, you can also have hypercalcemia. Which conditions you have high level of 1-alpha hydroxylase? More expression. Very important in a neonatal period. So this can come to you, a neonate comes to you with dehydration, with fever, high calcium. They have got skin nodules which are violet in color. They are painful, tender and high calcium. Nimisha?
Activity of 1-alpha.
Yes. Happening in where? What is this condition? Multiple skin nodules, firm, tender, violet looking and hypercalcemia. So fat necrosis. So when you have fat necrosis, macrophages come there and that macrophages start producing more 1-alpha hydroxylase. Similar macrophage activity can occur in sarcoidosis, which causes hypercalcemia. in tuberculosis, which can also happen because sometimes it may cause those problems from that regards. Of course, problems in testosterone activation, conversion into DHT will cause XY-DHT, which is 5-alpha reductase deficiency, and problem in conversion to estrogen will cause aromatase deficiency, causing XX-DHT. So again, metabolic problems can already be there. So AVP, we know this is the vasopressin, which basically has got these nonapeptide. Vasopressinase will destroy it in 5 to 10 minutes. Now, this vasopressinase cannot destroy DDAV. So, when we have the analog has been developed which is resistant to vasopressinase, which is minerin, and this is what we use for treatment of diabetes insipidus. From that perspective, the half-life increases. Now, as we were discussing, the placenta produces vasopressinase, which destroys that, and that's why you will have DI-like picture in pregnancy, and often it is seen in those patients who have an X-linked offspring with DI. Mothers will develop polyuria during that phase. So this is that case we were discussing about. 24-year-old lady with pregnancy and polyuria. Child had nephrogenic DI. This lady has low urinary osmolality and has this. They were managed with DDAVP. Now, how will DDAVP help? If you give AVP versus DDAVP, which will be more effective? Why? Because the problem is, so vasopressinase, this is vasopressinase resistant. So even if your vasopressinase is very high, doesn't matter. So in pregnancy with DI, you just give minerin, but don't give too much because anyway they have fluid overload that can cause more problem in that regard. So vasopressinase resistance. Now thyroid, we all know, is again a prohormone, T4. It is converted into the active form T3 via the deiodinase 1 or the inactive form RT3 using the MDI3, and the fetal metabolism is more towards anabolism rather than catabolism. So the fetus wants less thyroid or more thyroid?
Yes.
So you want to be hypothyroid. But one area of the fetus needs a lot of thyroid, that is for growth, for development, which is the brain. So in a way, this is very smartly achieved by the fetus, that everywhere else, the DIO1 activity converting T4 to T3 is less, reverse T3 is more because your DIO2 is active, DIO3 is active. But in the brain, you also have another enzyme which is active, which prevents this hypothyroid effect on the brain. So that is something which is important. So fetus, you have got more MDI3 or DIO3 activity, while MDI1 is low. As soon as they are born, the thing will change because now you want thermogenesis to increase your temperature, and there it comes to be in that regard. And that has significant implications on this case. This is a 10-day-old boy who was born preterm, phototherapy, ventilation, everything was fine, but thyroid levels are low. FT4 is low, TSH is normal. What do you think? Will you treat this child or not? So why do you think the FT4 is low in this case? This child is preterm. So in preterm, what did we say? Fetal physiology is hypothyroid. So this child has not come out of that axis. It's still in that phase. So he was born accidentally early. So this FT4 is not really low. So unless there are features of other features of central hypothyroidism like micropenis, like midline defect, like hypoglycemia, you will not treat. Treating here will be worse. There was a randomized trial about treating 28-week neonates with thyroxine. They found worse result because body is conserving yourself. If you give thyroid, you will cause more harm in that regards. The child also has dopamine, which has an effect on. So this TSH is not going up because of the dopamine as well. So remember, thyroid is low throughout gestation. Now you have brought this child out here. So of course at this 28 week, the levels will be low. So you cannot use the normal mature term neonate criteria here. You have to think of transient hypothyroxemia of prematurity in that regards. Now another example is a non-thyroidal illness. So non-thyroidal illness, earlier we used to call that as sick euthyroid syndrome. Now, what does the body want during sickness? Hypothyroidism or hyperthyroidism? Hypothyroidism. And how will you achieve it? You.
Right.
So more MDI3 activity. What about MDI2? So yes, high or more or less? More. TBG? Sickness will have an effect on TBG. So basically what happens is that you will have a low TSH because as you said, MDI2 is more. Now, if the TSH is very, very low, then only you get concern. High TSH will always be concerned, but low TSH only be concerned if the levels are too low. T4 level will be low, but because TBG is affected because of illness, it becomes much lower. FT4 will be low and T3 will also be low. So do not do thyroid functions in everybody who is sick, only if you have features like features of thyrotoxicosis, tachycardia, atrial fibrillation, hyperthermia, or features of mixed edema coma, which is basically you have got bradycardia, coarse skin, encephalopathy. Then only you do the test, otherwise you don't do the test unnecessarily. So 6-year-old boy with meningitis, TSH is 0.1 and FT4 is 6. So do you think this is central hypothyroidism? So low TSH, low FT4. So here you have to think of other forms. Now, what causes low TSH in this scenario? You said MDI2, but what is the major regulator of this TSH?
Is a regulator of TSH.
Why is this TSH low?
Patient could be other medications are used here.
Anything else? Which stress response causes low TSH? So if your cortisol is the cause, it should be high. If the cortisol is not the cause, it should be low. Then it is NPHT. So the quickest clue, this is a very, very important clue in somebody who is sick, you should look at the cortisol level. If the cortisol is high, this is a stress-induced response. This is not your hypothyroidism. This is classically a non-thyroidal illness and you don't need to treat. What do you expect the course from here?
The child gets healed with meningitis. Eventually, first the TSH response will come and it will look like some clinical hypothyroidism.
So you will have a lag phase from TSH to T4. So if you follow it up quickly, you will find TSH is high, FT4 is normal. So you will say, okay, this looks like a primary hypothyroidism or a subclinical hypothyroidism. So this is non-thyroidal illness in that regards. Now, vitamin D metabolism, already we have discussed, it's very, very important. So vitamin D is converted from the liver by 25 hydroxylase to 25 OHT. From there to calcitriol using 1-alpha hydroxylase, and it is inactivated by 24. So if you know, every part of it becomes important when you think of diagnosis in terms of treatment and in terms of cause. So somebody who is on anti-epileptic drug develops tetany. What are you thinking of? Inactivation of vitamin D?
Inactivation of 25 hydroxylase.
Yes, so more activation of 25 hydroxylase. So you are destroying your vitamin D with phenytoin or phenobarbital. What about somebody has a liver disease, has rickets? Do you think it is because of 25 hydroxylase deficiency? No? Then what's the cause? And somebody with renal failure has rickets, is it because of 1-alpha hydroxylase? Renal rickets can be because of 1-alpha hydroxylase deficiency, but hepatic rickets is not because of 25 hydroxylase. That is a big question. Why?
Large amount of
Yes. So 25 hydroxylase is huge. If you look at the levels, it's 1,000 times more as compared to 125, 1-alpha hydroxylase. So only when the whole liver is gone, then only you will develop rickets. But if you have a child with rickets and liver disease, you should think of other things like malabsorption, like styrosinemia, cystinosis. So you have RTA, which is causing galactosemia, which is causing that, and then you have an added liver disease. So 25 hydroxylase is in bulk amount. Its deficiency is not going to cause rickets. Its deficiency is there only because of too much liver damage only from that regards. And 1-alpha hydroxylase is the major factor to consider that. Problem in 1-alpha hydroxylase is classically known as VDDR2. Problem in 24 hydroxylase causes hypercalcemia, which means you do not get inactivation of vitamin D. So then you develop hypercalcemia. What does problem of 25 hydroxylase cause?
Decreased
Yes,
VDDR type 1,
VDDR type 1,
type 1B.
1B. Yes, so it's a specific form, rarer form, in which, so what will be your 25 OHD level there?
That will be good.
Yes, so how will you treat them?
You have to keep the higher doses of
Conventional vitamin D. That is how they will respond. So 2-year-old boy with rickets, no response to vitamin D, hypocalcemia, hypophosphatemia, high alkaline phosphatase, vitamin D is high. Next step.
it's a refractory ricket, no responsibility. Can go like to see from the first A level. The acidosis and go down first.
Yeah.
Okay, then in acidosis, why do you have high vitamin D?
High,
25 OHD, why is it high?
given once that.
Okay, so there is no acidosis.
Then we can look for the A level, calcitriol level. We have to look for that.
Calcitriol is low. So then you're dealing with a
Type 1.
VDDR1 in which there's a problem in activation. Can VDDR1 have acidosis? Or vitamin D deficiency, can it have acidosis?
Can have, sir, because high PTH level will be there in hypocalcemia. That
So
can-
persistent hyperparathyroidism can cause Fanconi-like picture. So mild metabolic acidosis with severe rickets does not mean RTA. If you have RTA, you either have very low phosphorus, that is the proximal RTA, or you have very severe acidosis, that is distal RTA. So just with mild acidosis, do not jump that this could be a scenario. So this is most likely a VDDR1. 1-year-old boy with bone pain was given cholecalciferol sachet. Now comes to you with abdominal pain and polyuria. So there is a hypercalcemia which is developing. Vitamin D is very, very high in that scenario. So how will you counteract this?
24 hydroxylase.
So you want to increase 24 hydroxylase, which is not easy. You can decrease 1-alpha by something. Which drug?
Steroids.
Yes, so this is a classical scenario you can do. But if the problem is in 24 hydroxylase, as I discussed, this is known as idiopathic hypercalcemia of infancy. And some people say Williams syndrome. The hypercalcemia is because of this 24 hydroxylase, which is there. But here, if you give them steroids, you will be able to decrease conversion of 25 to 125. Your 25 will be high, but it is not going to cause too much problem from that regards. If it is iatrogenic, which is the most common scenario, we give it for 3 to 6 weeks also.
But if the mutation is on the 20,
No, that is a different thing altogether. Then you have to avoid vitamin D long term. Short term, you will give that. And then you have to avoid all forms of vitamin D, because if you give them vitamin D, they will develop toxicity. If you don't give, that is okay. They will not have a problem. If you are in sunlight, will you develop vitamin D toxicity? Why?
it is converted to lumisterol and that is
Yes. So there is always a fallback mechanism. If you have too much sunlight, it prevents from there. What causes pigmentation in humans? So different regions, people have different pigmentation. So what causes that?
melanin.
Yeah, melanin is causing, but what controls melanin?
Plus UV light.
So why? That is the question. If you have too much melanin, what will happen?
Too much melanin. So it will be like a tumor like it. So there will be a huge pigmentation.
So what's the problem?
Problem will be the sunlight will be not, UV light will be not entering and there will be vitamin D deficiency increase.
And if you have too little melanin, what will happen?
Little, the problem will be the UV light exposure will be more, chances of skin malignancies will be much higher.
Through what mechanism? So the entire pigmentation, ethnic variation, whatever you talk about dark skin, this thing is all related to latitude, which we all know. So of course, in closer to the equator, people have to have more melanin. Closer away from the equator, the melanin is less. It is all a balance between two vitamins. One is vitamin D, other is folic acid. So if you have too much sunlight, you will have a problem in folic acid metabolism. And that is going to take you towards that melanoma and all that pathway. Because that is involved, homocysteine, then all those things start working. If you have too little exposure, you will develop vitamin D deficiency. So equator people are bad because they're getting so much sunlight, they are becoming more pigmented to avoid that malignancy. While people who are in the tropical or the upper regions will be becoming less pigmented to ensure they don't develop vitamin D deficiency. But by mistake or by whatever reason, if the people who are pigmented go to regions which have got more sunlight, they will have a much higher risk of malignancy. True or false?
Melanin is there.
So they will not develop melanin in one generation.
Take time, sir.
So that generation will go now. So which condition do you think of where people who are not supposed to be in sun went to that area and there the melanoma became high? Which country?
Which country?
Yeah. Classical example is Australia, because where a lot of Europeans went and they had a lot of sun exposure, and that's why sunscreen and everything started from there. And how will you, because evolution is going to take thousands of years, how can you prevent this then?
Limited sunlight exposure, sir.
So cultural evolution, you wear more clothes. So can you think of one group of people who started wearing more clothes to prevent that? So originally the Arabs are not supposed to be from that region, Egypt and that region. So when they came there, they started wearing all the clothes to prevent sunlight exposure. So this is known as a cultural evolution. So this is how it's not just the actual evolution, the human process also adapts to scenarios. So people are using a lot of sunscreens to prevent that. So that is a thing to discuss on that. We'll just touch base briefly about cortisol and its metabolism, and then we will close from there. So cortisol and cortisone are structurally similar. So we all know there's just a sort of a one, it's a basically a problem of oxidation versus reduction. So there is a bivalent action which is happening via 11 beta HSD2, which is converting cortisol into cortisone, and 11 beta HSD1, which is converting cortisone into cortisol. So it's activating versus inactivating. That's the thing you should remember at this moment. So we have a 1-year-old boy with failure to thrive. There is polyuria, hypertension, hypokalemia, metabolic alkalosis. So hypertension, hypokalemia, alkalosis, what are you looking at? No, electrolytes is low, hypokalemia is there. So this is increased aldosterone effect. That is what we are looking at. So how will you proceed further? Okay, good. So genitalia is normal, renin is low, PRA is undetectable. This is a normal male. So this is most likely AME versus Liddle syndrome. These are the two possibilities. And here, if you look at the response to spironolactone, that will give you a clue. So this is the issue of apparent melanocorticoid excess. The problem here is not in the gland. The problem here is not in hormone production. The problem here is not in the receptor. It is the inactivating enzyme which is defective. So if you think of it, how complicated hormonal physiology can be, that this is cause of the disorder in that regards. Androgens, of course, testosterone is the classical pro-hormone in males. It is activated via 5-alpha reductase to DHT, while in females it is converted to estradiol to cause a lot of other things like bone growth and other scenario and adipocyte. So 10-year-old girl with clitoral enlargement all upon, phallic size is 2.2. So this child all of a sudden was reared as a female and suddenly the penile size is increasing or a clitoral size is increasing. What conditions can cause virilization at puberty?
The three conditions can is relation during puberty. One is 17 beta HSD effect. That is 5-alpha reductase, third is partial
So
action.
most common, most important, most common,
Yes.
5-alpha reductase. So when you say penis at 9, it is basically the term is from 5-alpha reductase. So other conditions can also be realized, but the proper visualization classical presentation is 5-alpha reductase only, and there are bilateral gonads. So this was a XY individual who presented with DSD and now during puberty. So why is there visualization here now?
Because during puberty, there are productions of testosterone from the gonads that causes much more variation.
So the problem here is that you are not producing DHT. Now testosterone and DHT both act on the same receptor, but you will need 100 times more testosterone to act. So this person, the problem was they were not producing enough DHT, but now puberty testosterone becomes so high. So it starts acting in that and causing virilization. So this is known as a penis at 9 syndrome classically. And from our mythological, which character would be fitting into this? Very unique character who is described in the mythology very classically. Born as a girl, comes back as a male and plays a very important role. Shikhandi. So if you read Mahabharata, that is the classical depiction that born, who was Shikhandi, you know? Viva?
जो
He killed Bhishma.
Krishna,
So he was the brother of.
what say?
Mhm. So that is from the last birth. This is supposed to be he was reincarnated as a. Hmm. Yes, absolutely. So he was the brother or sister, whatever you can say, of Draupadi. And he was left out because the father wanted revenge. And that's why he left out the girl. The girl went to the jungle and came back as boy. So that was the Shikhandi basically. So it's classically 5-alpha reductase if you go by the same story, which is very well depicted there. So this is 5-alpha reductase. Now, same problem in females can also cause a problem. If testosterone is not converted to estrogen, you will have aromatase deficiency. And this is how they will present. They will present to you with what is the most telltale sign of a child with aromatase deficiency. So this will be XX-DSD with maternal virilization, which is what is going to be the case. So this was a case who presented to us, referred as quote unquote CH. But when we dig deeper, we found that this was a aromatase deficiency from that regard. So enzyme defects can cause a